And I would like to welcome you all to the fifth and last lecture of the 24th Annual Lefebvre Winter Series on Aging. As you know, I'm your host, Elena Volpe, and by now you should also know that this lecture series is in memory of Dr. Edward James Lefebvre. Dr. Lefebvre started geriatric practice actually on the Galveston Island around 1939. And he taught internal medicine at UTMB and became also later the director of the Turners and Moody's House, which is now the Meridian Retirement Community. And before he died, UTMB developed the geriatric division, and his family decided to actually support this lecture series with an endowment. So today I'm really delighted to introduce Dr. Stephen Wallace. Dr. Wallace is a professor in the Department of Community Health Sciences at the UCLA Fielding School of Public Health. He's an associate director at the UCLA Center for Health Policy Research. Dr. Wallace received his undergraduate degree from the University of California, Santa Cruz, and his doctorate in sociology from the University of California, San Francisco, where he also started his academic career as an instructor. He then became a consultant for 1 year at the Urban Institute in Washington, D.C., and after that, he went back to academia as an assistant professor at the University of Missouri in St. Louis. However, the arch wasn't enough to keep him in the Midwest, and so and hold him away from California. And so, after a couple of years, he accepted a faculty position at UCLA, where he's completed his academic growth to a position he holds today as a professor. Dr. Wallace is a leading national scholar in the area of aging in communities of color. He studies access to healthcare and health equality for older people, public policies that impact older adults and immigrants, and leads projects to build organizational capacity in communities of color and investigate equity of access for the elderly to health resources within and between countries in Latin America. He's published more than 140 papers and dozens of policy briefs and reports. He has also testified at state legislative hearings and in other forums, and his research has informed state laws. His research has received broad media coverage from newspapers, such as the New York Times and LA Times, and other media outlets such as NPR and Fox News. Dr. Wallace is currently the principal investigator of an NIH-funded project that is studying how state-level policies for immigrants impact their access to healthcare and health status, and is the co-principal investigator for the evaluation of NIH Marquis program to diversify the NIH workforce, and is also the director of the Coordinating Center for the NIA-funded Resource Centers on Minority Aging, or RICMAR, of which we are also part of the RICMAR network coordinated by Dr. Wallace, with our own Dr. Marquides, who recently received funding for one of these NIA centers. Dr. Wallace has received many accolades, including the Fulbright Fellowship to research and lecture in Chile, and he also has received honors from various societies, including the Gerontological Society of America, California Council on Geriatrics and Gerontology, and the Health Initiative of the Americas. So I'm very happy tonight to host Dr. Stephen Wallace as a speaker for the last of the series of the lecture of the winter series on aging. So the title of his talk is Economic Insecurity Among Older Adults of Color, Housing and Health as Cause and Effect. So Dr. Wallace.
Thank you for the nice introduction. I see we're almost out of time, so I'll take questions. No. So I'm going to talk a little bit today about what is economic insecurity, how we measure economic insecurity or poverty in our country with the federal poverty guidelines, and then an alternative that I've helped develop called the Elder Economic Security Standard Index. Discuss the relationship between economic insecurity, housing burden, and poor health, and end with some possible solutions. I talk about this line of work that I do as my fun research because it actually has immediate impact. A lot of the stuff that I do, mentioned the journal articles that I do, those often get noted, some are widely cited, but this is the work that's actually ended up in state law. A lot of agencies have used it. Some local agencies are using it as part of their housing assistance. So it really does provide a lot of feedback for me as an individual in making a difference. Okay, so what is economic insecurity? It's that balancing act. It's insufficient money to pay for a minimal but decent level of need. So I think the important part here is the decent level of need. And I'll show you shortly what some of those challenges are. So the balancing act is not just on a tightrope. This guy, by the way, is 82 years old. It was his last tightrope walk before he retired. But the tightrope walk is, do I pay rent or refill my medications? Do I buy enough healthy food to last until the end of the month or pay for utilities? And I would say that since we live in the richest country in the world, that seniors who have helped to build this country, raise their families, and fought in our wars shouldn't have to play a balancing act every day of the month. So, how do we measure economic insecurity? We used to say that it was an impressionistic measure. There were lots of people during the Depression who were out of work. Local governments were overwhelmed with people needing assistance. But the government really had no specific measure for indicating the level of economic adequacy or insecurity in the country. So in his second inaugural, Franklin Delano Roosevelt said, describing the state of the country, that I see 1/3 of a nation ill-housed, ill-clad, and ill-nourished. So that was the level of precision that we had, even though there were breadlines, there were homeless encampments, but there was no actual measurement of how many people didn't have enough to get by. So then, in the State of the Union address in 1964, Texas native and then President Lyndon Johnson declared a war on poverty. So if you're declaring a war on poverty, you need to know when you've won. And if your metric is this sort of vague, 1/3 of the people aren't doing well, that wasn't precise enough. So they needed a standard measure of poverty that was high enough so that they could see progress, right? If the number was too low, there'd be nowhere to go lower, but not so high that the United States looked bad. So if you remember in the early 1960s, we were in an active competition with Russia over the best economic model, particularly in some of the developing countries. And so you didn't want the US to look bad if you said half the people were poor. That would be easy to bring down, but would not be very good geopolitically. What they did is they took the best knowledge that they had at the time and looked at how much money people spent for their average expenses, average daily expenses. Now, we have lots of surveys these days, but back in the 1960s, there wasn't that much data. So in 1963, when they were developing these measures, the most recent data that they had on family expenditures was from 1955. So already it was getting old. And what they found was that about 1/3 of the expenditures in the average family in the United States went for food. And then they tried to figure, well, how do we update that? That was 1955. We're now in 1963, 64. How would he figure out what the cost is now? So they said, well, if 1/3 of it is food, we need to find out what the costs of food are. And the Department of Agriculture at that point was doing an annual survey of how much it costs to put food on the table. And they had 4 different measures, from sort of a middle-class food standard that included meat and potatoes and all sorts of things, down to the emergency food plan. And the emergency food plan, I like to say, is like the post-Katrina food plan, or the post-Ike, in your case, food plan. So it's short-term. It's like how much the minimum amount you need to survive, not to thrive, but just to survive. And they went through the different levels, multiplied them by 3. It's kind of like backwards engineering, and looked at how many Americans would be poor. And they ended up with the very bottom level of the emergency food plan, and multiplied that by 3 to get what was then in 1964 the poverty level. So that was the standard of living. Anybody recognize who this is? Who is it? Yeah, Leave It to Beaver. So this was the standard of living. You know, you watch the, whatever the channel is that's got the old TV series. That was the standard of living that they were looking at. So that leads to a couple problems for measuring what we consider the standard of living. Since 1964, the number goes up every year, but it only goes up by inflation, the consumer price index. So it doesn't reflect the increases in the standard of living, only in the cost of living, a 1955 style of life. So how many of you had air conditioning in 1955? How many of you have air conditioning today?
People were there.
Well, okay, of those of you who are alive in 1955, air conditioning was not known. I mean, you know, maybe in some movie theaters, but residential houses didn't have air conditioning. Now it's standard. You didn't have the internet, you didn't have cell phones, you didn't have microwaves. All these things that are part of the standard of living now didn't even exist in 1955. So those aren't included as part of the cost of living of the federal poverty line. So doesn't been adjusted for the standard of living. Second problem is it's a single value for the United States. So when you hear about the poverty line, and you say, oh, what is it in Galveston versus in New York City? It's the same, the exact same amount of money, which is sort of counterintuitive these days. But in 1964, they didn't have any regional data, so they just made one line. It doesn't reflect the type of housing, and I'll talk a little bit about housing later on. But if you rent or if you own, you have very different housing costs. And it also does not reflect the higher medical costs of older adults. So it was based on a family distribution of spending. And as we know now, medical care costs go up in older age. Even with Medicare and supplemental insurance and so forth, it's a higher cost. So what I like to say is that the federal poverty line is about as useful as this car. Anybody recognize the car? Edsel. It's an Edsel. And what was famous about the Edsel? It was a lemon, yes. It was the biggest disaster that Ford ever launched. So yeah. Well, it's a little bit of a yellow cast. It's wore off in the sun. So when you think of the federal poverty line, think about the Edsel. So let me go through each of those 4 problems of the federal poverty line, and then I'll give you a solution, and then we'll talk about some other issues. So in 1964, when they came up with the federal poverty line, it was $3,142. When you compare that to 50% of the median income, so half of Americans made more than this, and half of Americans made less than this in 1964. And in Europe, the poverty line is frequently used as 50 or 60% of the median family income. So you can say, okay, this is probably not a bad indicator. And as you can see, the poverty line using their kind of back of the envelope measure came pretty close. It was about 42% instead of 50%. 2017 is the most recent data available now. Half the median income is $47,400. And the federal poverty level for a family of 4 is $24,000. So it's gone from 42% of median to 26% of median. So as the country got wealthier, the poverty line did not reflect that. That reinforces the problem with not keeping up with the standard of living. Okay, problem number 2. It's one number nationally. So as I said, this doesn't pass the sniff test. So you've got 2019, the poverty line for one person is $12,490 everywhere, in the entire country. And I don't need to tell you that costs differ. And what drives the cost differences in most of the country is housing costs. So this shows you the fair market rent, which is Housing and Urban Development, federal agency, surveys every year the cost of renting a variety, 1-bedroom, 2-bedroom, and so forth, apartments around the country. And they will provide subsidies to help you up to, fair market rent is at the 40th percentile of the median rent. So this is a modest, not a high living apartment rent. And as you can see, San Francisco is currently the most expensive city in the continental United States. So a 1-bedroom apartment is about $2,200 per month to rent. And that's 1 bedroom. And when I give this talk in San Francisco, they go, can you show me that place? I'd like to rent it. Right? So there are not a lot of supply out there. In New York, it's a lot less. LA is close to New York. You go down and you say, oh, well, there's quite a difference. So Houston is about a little more than half of New York. But then you go down to Brownsville and it's even less. So you can see there's a 4 to 5-fold difference in objectively the same quality of housing, whether you're in Brownsville or whether you're in San Francisco. And so the federal poverty level does not reflect those differences in the cost of living. Third issue is the costs differ by housing type. So the popular image of older adults is that all of them own their homes and they're all paid off. So it's like no housing costs. The reality, though, is that across the country, about half of older adults own their homes free and clear. So the popular image of older adults living in their property is about half right. The other half are either renters or are still paying a mortgage. And what this shows is that the lowest income older adults under the federal poverty line, 40%, 2 out of every 5 are renting. So they're the ones that are facing different costs year after year because rents change. Those with their mortgage paid off may need a new roof or taxes may go up, but they're a lot more insulated from changes in cost of living than people who are renting. And as you go up the income scale, while the proportion of older adults who own their homes and have it paid off stays relatively constant, there's a little jump here. The number of renters goes down dramatically, and the higher income older adults are more likely to be owning their home but still paying a mortgage. So there's a big distribution of different housing arrangements, and I'll show you those actual costs in a moment. But this shows you there's a wide variation in the population, and especially at lower incomes, a lot of older adults are in the rental market. Okay, so problem number 4 is that seniors have different income needs, different spending patterns than younger adults. So using a single family income profile isn't appropriate. So do you remember what proportion of the federal poverty level was based on food? 1/3. And so you can see here, currently, this is the most recent survey, 2017, sort of across middle age and old age, it's about 12 or 13%, pretty consistent. So the proportion of your income that goes for food is a lot less. In contrast, the proportion that you spend for housing is a lot more. And just showed you the variation in housing costs. This is the US average. But instead, if you wanted to multiply, you multiply the cost of housing by 3, not the cost of food by 3. And then the big part that in 1955 was not a very big part of household expenditures at all is healthcare. And as you can see, it goes up as a proportion of income so that it's 15% in the oldest ages. So this other is comprised of all sorts of other things. It's entertainment, it's clothing, life insurance, education, all sorts of other items. But no other item goes above 10% in here. So it's made up of lots of little pieces. So these are the big pieces. And healthcare is the one that, in particular, is a problem for older adults. So to deal with those 4 problems, we've come up with an alternative that addresses them. So the Elder Index is based on the actual costs of basic necessities for older households. So it actually reflects current costs of living and the current standard of living. So it's not a 1955, it's not Lever to Beaver standard of living, but it's, I don't know, what's the current popular family TV show. So it's that standard of living. It's done at the county level. So there's a different elder index at each county. So it reflects variation in cost of living across the country and urban and rural. It's calculated for both owners and renters separately. So people who have different costs, who are facing different needs, have a different amount. And it actually includes amounts for health insurance and out-of-pocket healthcare costs and other actual healthcare costs. So the cost of healthcare has been going up faster than the cost of inflation for many years, and so it reflects what people are actually needing to spend. When we designed this, we actually went through and designed a like I was saying at the very beginning, a minimal but decent standard of living. So for food, which I'll show you here, we didn't use the emergency food plan. We used the next one up to say, okay, what is the actual cost of food, but not rice and beans every night for 365 nights, but a low-cost food, and does not include any like food out of the home. For housing, it's the housing and urban developments, fair market rent. So that, once again, it's a little below the average or the median housing value in the area. Transportation is local only. So if your brother or sister passes away and you want to fly to a funeral in New York, that's not included in here. Healthcare is basic healthcare costs. In counties that have a high Medicare Advantage penetration, we use the Medicare Advantage rate. If they don't have a Medicare Advantage, we use the AARP supplement and a standard set of private health insurance, and then miscellaneous. So in Los Angeles, when you add this all up, so there's sort of three stories here. The first story is difference in housing costs. So as you can see, the difference between somebody who's got their mortgage paid off and somebody who's renting, and these are actual costs. We take census data and we say, what is your taxes, utilities, all your housing costs if you have a mortgage paid off. In LA, it's about $600 a month. If you're renting currently in LA, you're paying about $1,100 a month. So there's a big difference there. Humboldt County is a rural county in Northern California. And so you can see the differences here. So $600 for a mortgage in LA versus under $400 in Humboldt. That's just the cost of housing difference. And similarly in the rentals, there's a big difference. So even within California, that's a high cost state, there's significant regional variation. Food costs are pretty similar, transportation pretty similar. The other big cost difference in California is healthcare. So in Los Angeles, has a very high 50-60% managed care penetration rate, which pays you basically have low or no copayments, low or no deductibles. They cover your medications. They offer you other benefits, some dental, some eyeglasses, all sorts of things. So anybody want to guess how much per month that costs extra? If you have a Medicare Advantage plan in Los Angeles? All these extra benefits? Some places in the country you can pay $300 a month for Medicare Advantage. Zero. So because of a quirk in the law, Medicare Advantage rates are based in part on the fee-for-service rates. Fee-for-service in Los Angeles is very expensive. So what they pay Medicare Advantage plans is quite high. And so they can offer Medicare Advantage plans for no extra money in Los Angeles and the Southern California area. So you get all these extra benefits. The only difference is you've got to go to Kaiser or you've got to go to the Blue Cross Advantage plan doctors. So you can see the difference. It makes a huge difference monthly. This is for one person. In Los Angeles, the costs are much lower than they are up in Humboldt. You add it all up and you get about $25,000 a year is the basic income need for a senior in Los Angeles. The federal poverty level, that one number nationally, is about $12,000. This is 2017. So it's about 200% of poverty. So when we were first calculating these, before we actually crunched all the numbers, we said, oh, this is going to cause a lot of conflict because we'll see rural areas are so much cheaper. The coastal areas will say, oh, we want to use this. And the rural areas will say, you're disadvantaging us. But because of the cost of health care, it's actually only about $1,000, $1,500 difference when you add it up for the year. So it's $23,000. Not quite 200% of poverty, but pretty close. So this is just a graphic illustration. Here's 2017, the poverty level. This is how much more a renter needs. So you need more than in Los Angeles City, twice as much as the poverty level. Even an owner with no mortgage at $18,000 is going to need about 50% more than the poverty level. So in no instance does the poverty level even equal the amount of money people need to live. So here's your quiz. Do you think Texas is any better? No. You must be locals. All right. So housing is less than in Los Angeles. And so I picked up Harris County and Brownsville for sort of a more urban, more rural comparison. And so once again, you can see the HUD cost for rentals is lower in rural and more in urban. Mortgages similarly are different. Healthcare is a little bit different. But you add it all up and you still come up with $21,000 in change for a minimum. Once again, I have to say a minimum. It's not luxury living. You're not having lots of discretionary expenses, standard of living if you're a renter, and $19,000 if you're an owner. So it's not a huge difference. And compared to the $11,880, which is so this is a slightly different year. The numbers are slightly different. But it's still about 180%. Not quite double, but it's approaching double. And even an owner with no mortgage in Brownsville needs about 50% more than the federal poverty line. So in no area in Texas and no area in California does the federal poverty level actually match what you need. And the federal poverty level is used for eligibility for food stamps. Proportion of poverty level is used as eligibility for Medicaid. It's used to allocate dollars for low-income areas through a variety of housing and urban development programs. So it's a number that's used as a reference number everywhere in the country. And in nowhere in Texas or California is it actually an adequate amount. So who gets left out? We talk about the group that is an income higher than the poverty line, but less than the elder index, the hidden poor, because that's a group that's sitting just above the poverty line, but they really don't have enough money to make ends meet either. And they typically don't qualify for most programs designed for low-income individuals. So we did a policy brief on this a couple years ago looking at that. So if you look in California at the racial and ethnic distribution of people under the poverty line, so there's a couple stories in this data. First is that if you look at the number below the federal poverty line and those above the federal poverty line below the elder index, this is, in some cases, the yellow is even more disadvantaged because they don't qualify for a lot of public assistance programs. The rates are relatively similar. So if you've got about a third under the poverty line, you've got about a third above the poverty line, but still under the elder index. For Latinos, more above the elder index. For African Americans, a little bit less. But in all of these, you end up with about 2/3 below the elder index. This is for seniors living alone. If you did all seniors, the pattern is generally the same, but the total numbers under the elder index are a little bit less. And then for non-Hispanic whites, the number above the elder index is about twice the number below poverty. So if you distributed these out by the size of the population, this is the group that dominates when you talk about senior poverty. And then there's a huge group sitting just above the senior poverty level. This also varies by the different housing arrangements that I mentioned. So this is still seniors living alone. Once again, the pattern is the same when you look at all seniors. Numbers are a little bit lower. So about 2/3 of older adults living alone in California are under the elder index. So if you look at African American women renting, it's about 90%. So you really don't need to do an income eligibility if you know some of the demographic characteristics in the state. Owners with a mortgage, much less in poverty. That's because they have higher incomes, but they're spending a lot of their income on their housing. And so you still have about 40% below the elder index. And the best off are owners with no mortgage, still about a quarter that are struggling to make ends meet, even though they don't have monthly mortgage payments to make. So what is the impact of economic insecurity on housing, food and nutrition, and healthcare? I'll start with housing. So the Department of Housing and Urban Development has a metric that they call housing burden. And this has been used widely. If you spend 30 to 50%, 30 to 49.9% of your income on housing, you're considered housing burdened. If you spend half or more of your income on housing, you're considered severely burdened. And this shows you among the elderly, by county, the proportion of the county where seniors are cost burdened. So this is both renters and owners. So, and this is the percentage of seniors in the county who spend more than 30% of their income on housing. And of course, you can see some coastal counties are very high percentages, Chicago, Miami-Dade, right? So the high-cost places that you might guess. But if you look at the yellow, these are actually 30 to 40% of the seniors in these counties. So is this Houston area? Yeah. So once again, you think, oh, well, the cost of housing is less here, but then incomes are less as well. So people end up spending a lot of their income on cheaper housing, but it's still more than 30% of their housing. The places that are the cheapest are West Texas. Is that a surprise? Some areas in Colorado and so forth. So the places with no color, they don't have data on. But what this shows is that overall, when you look at housing burden, about a third of all seniors nationally face some sort of housing burden. Even though rents and mortgages are lower in a lot of states, Louisiana, Alabama, Florida, you end up with high housing burden because the incomes are lower as well. And so it's a national issue. It's not just a, San Francisco, New York issue. It's more dramatic there when you look at the amount of money is involved. But when you look at a proportion of person's income, they're struggling to do that balancing act between paying rent and paying medications or paying rent and buying food. It occurs everywhere. So relevant for here as well. Okay, so housing burden. Housing has become a sort of a hot topic again. I don't know where it went, but just the last couple years, there's a lot of research going on around homelessness, around housing burden, probably driven by the rapidly increasing rents in a lot of areas. So what this shows is that among older adults households, age 65 and over, the housing burden and the extent of housing burden increases as you go from no mortgage to renters. So renters, probably understandably, are most likely to have the greatest housing burden. And a lot of that, over half of it, is severe housing burden. So this says over a third of seniors in California are spending half or more of their total income on rent. So that doesn't give you a margin for doing much else. It's actually close to 2/3, about half of owners with a mortgage, and even about 15% of owners with no mortgage. Looking at it by income, once again, if you're below the federal poverty line, independent of your ownership status, about 2/3 are severely cost burdened, another 17% moderately cost burdened. So you've got, if you are looking at a renter and they're low income, they're almost definitely going to be struggling to pay their monthly rent. So this looks a little California and Texas about who owns and who rents. And what this shows is that, first of all, renting, well, this doesn't show renting is associated with income. Because renting is associated with income, these are only low-income seniors. So this is limited to those under 200% of poverty. So in California, it's most of those under the elder index. And in Texas, it's by far the majority of those under the elder index, and maybe a couple right above it. So what you see here is that in Texas, the white are renters. So renting is a little less common in Texas than California. Ownership is a little bit higher in Texas than California, but there are definite patterns by race and ethnicity. So about 2/5 of African Americans and Asians, these two groups in Texas are renters, right? So there's a big difference versus about a quarter of non-Hispanic whites and about a quarter of Latinos. In California, the rates of renting are higher, but similar patterns. So the most common group to rent are African American elders, and more so in California than in Texas, Latino seniors as well. So what is all this? So one of the implications of being a renter is that you're more likely to be less attached to your housing. Renters are less stable in terms of housing. So this is nationally. This is the years living in their current home for seniors. So if you've got a mortgage, if you own your home with no mortgage, so it's paid off, this is the number of years distributed out that people in that category who are seniors say they've lived there. So about half of all seniors with no mortgage have lived in that same house, not just the same community, but the same house for 30 years or more. So most older adults, we talk about wanting to live where as they age? At home. They want to live at home, and they want to age in place. So they're not interested in moving across the country. We all hear about seniors from New Jersey retiring in Florida. Then you hear about them getting sick and moving back to New Jersey. But half of all seniors are living in the same place they've lived for at least 30 years. If you're a renter, it's the inverse. So about half of all renters have lived in the same apartment for less than 5 years. So you've got a really dramatic difference here. This is a housing stable population. This is a housing unstable population. So economic insecurity is related to rent burden, and in turn is likely to lead to a lot of turnover, in part because rents go up. Very few jurisdictions in the United States have rent control. As your rent goes up, if you don't have much money, you can be forced out of your house to be able to find a better housing situation. So what happens if you're forced out of your house for economic reasons? So it's one thing to say, I want to move for amenities. I want to live on a golf course. Or I want to move closer to my kids so that I can be with the grandkids, right? Those are sort of self-directed moves. They're things that people do because they want to. What happens when you have to move because your rent goes up? In California, you usually cannot find a place down the street where your rents are the same. So you end up moving longer distances. And that can result in a whole host of problematic health situations. So if you're forced to move to a new area where you don't know people, where the cost of housing may be less, but it may be 20, 30, 40 miles from where you lived, you're going to end up with weakened social networks. So if you've lived in the same place for a while, you've got your friends, you've got your neighbors, you get to know people, and then you have to move, you have to start all over. So I remember when I was in college, I moved every 6 months, not necessarily by choice, but made friends very quickly. The older I get, the longer it is to make friends. So I've known Coco since 1984. So I would say that we're pretty good friends, but those of you that I met for the first time today, it's going to take a couple more interactions before I'd call you a close friend. There's an increasing interest internationally now in social isolation as a risk factor for health. And one of the ways they describe the risk factor of being socially isolated is that it's equivalent to smoking a pack a day of cigarettes in terms of life expectancy. So now if you smoke and you have friends, I'm not quite sure those counterbalance each other, so I still don't recommend smoking. But social isolation and loneliness are a major risk factor for mortality. So you're increasing those risks. In addition, older adults are high users of medical care and typically have long-standing arrangements with their doctors, their pharmacists, their local network of providers. And so if you're moving a person 30 or 40 miles and maybe they don't drive so well or they have other mobility limitations, you're disrupting the medical care networks as well. We did a study in California where they were forcing seniors who were dual eligible, had Medicare and Medicaid, to go into managed care. Up until the point about 6, 7 years ago, almost all seniors that had Medicaid, which was low-income seniors, were in fee-for-service. And they forced them to go into managed care, but then they allowed them to opt out. So they were forced in, but then they could leave. And in Los Angeles, 80% left after being assigned to a managed care plan. even though the managed care plans had extra benefits and services, and the whole idea was to provide wraparound services for long-term care. And the number one reason that we saw that people said they didn't want to go into managed care was they didn't want to change their doctors, right? So if you're dragging people away because they can't afford their housing, you're disrupting one of the most important relationships in the lives of a lot of seniors. So that's not good for their health either. And then also community services, whether it's the pharmacy down the street that delivers, or the corner grocery store, or any of the services that you've developed, you're starting from scratch with all of that. So this really emphasizes the interaction of housing and disrupted housing that happens because of economic necessities, and healthcare, economic insecurity, and some of the life course outcomes. So that was economic insecurity and housing. Economic insecurity and food. So this shows the proportion who are food insecure by the poverty line. So I don't have the elder index for every area in the country, so just using this as a crude yardstick. But the pattern is pretty clear. As you get poorer, the more food insecure you are. So food insecurity is not having enough money to buy nutritious food through the end of the month. So in that balancing act, am I going to pay the rent, or am I going to buy food? Well, if I don't pay the rent, I get thrown out, and then I don't know where I'm going to live. So I'll just cut down on food and maybe run out of food for a couple days at the end of the month. You see that food insecurity is about 40%, 1 out of 5, 20% of seniors nationally who are under poverty, about 10% for those basically in that hidden poor group, and very low, above 200% of poverty. So it struck me, so it's good to travel, looking at this regionally. I don't have Texas specifically, but food insecurity is highest in the South, controlling for income. So why might that be? Why would the South, at the same level of income, be more likely to be food insecure? Any thoughts? Fewer food pantries. Okay, so access to alternatives to food. I actually spent some time last weekend trying to figure this out. And one of the reports from National Food Pantry Organization pointed out that there were fewer food pantries in rural areas. So the proportion of a state that's rural versus urban, the South is more rural. So you have less access to food in rural areas through food pantries. And I don't know about within urban areas if there's also a lower concentration of food pantries. So that would be part of it, so less access to alternatives. So even within these are pretty broad bands. My guess would be, if you look at the average income in each of these categories, probably the average income of seniors who are below the poverty level in the South is lower, if that makes sense, than the average income of seniors on the coasts who are below the poverty level, so lower incomes. And then also, once again, in rural areas, you're more likely to be further away from food opportunities. I did some work in California on food insecurity and worked with a rural poverty center. And they pointed out that there are actually often more similarities between inner cities and rural areas than there are between rural areas and suburban areas. And in food insecurity, that was one of them. So we often talk about food deserts and food swamps in inner cities, and the food deserts also occur in rural areas. So when you look in California, the highest level of food insecurity is in the Central Valley. What's the primary industry in the Central Valley? Food. Agriculture, right? It's the breadbasket of the country, and they're the highest level of food insecurity. Part of that is very low incomes, but then it's all rural. There is no, discount grocery store that you can run down to. So you're dealing with higher, ironically, in the middle of where all the food is produced, your food costs more than if you go into Los Angeles or San Francisco and you've got the large supermarkets and discount stores. So you can see in both the lowest income group and the hidden poor, the South has actually the highest levels of food insecurity, specifically among older adults. So economic insecurity, is also highly related to food insecurity. Food insecurity is a problem, particularly for older adults, for a whole variety of reasons. A lot of medications that people take are supposed to be taken with food, and so if you're cutting back on food, there might be some interactions there. There are a number of health conditions that require special diets. Those are more expensive, so if you're food insecure, you're less able to follow the prescribed diets. And risks of geriatric symptoms, whether it's falls or other types of conditions, are also more likely if you're food insecure. So there's a whole raft of things where if you're economically insecure, you're more likely to be food insecure. So there's a cascade which is more likely to increase your health risks down the way. Economic security is also associated with problems in healthcare. So this is that same graph. It's just the outcome is problems paying medical bills the last 12 months. So here the scale went up to 25%. Here the scale goes to 20%. And lo and behold, the most precarious place to live in the country if you're low income is still the South. So close to 20% of both of these income groups report that in the past year they had problems paying for medical care. On the other hand, Western states were among the lowest. Part of this, probably particularly for the poverty level, is Western states have done a lot in expanding Medicaid coverage to low-income populations. And Medicare Advantage, as I mentioned, like in Southern California, is free. So if you're low income, but you don't qualify for Medicaid, you can still get extra health care benefits just by signing up for Medicare Advantage. So there's a variety of reasons why the West is lower here. I actually don't know that much about the Northeast, but I suspect there's similar dynamics that are happening there. So if you're income insecure, you're also more likely to have problems affording medical care or paying your bills. And if you have outstanding bills, what are you more likely to do than if you don't have outstanding bills on medical care the next time you're sick? You put it off. You don't go to the doctor. You delay refilling your medication prescriptions. You maybe do a shorter course of rehab. Whatever the medical care needs are, there's a big incentive for these folks to skimp on that. Okay, so I've showed you lots of sort of crosstabs. This is a logistic regression. So this says holding all these things constant. So is it is the difference by owner versus renter just a problem of income, or is it a difference in owners versus renters? So this is that same outcome, problems paying medical bills past 12 months, putting all these different factors together at the same time. So needless to say, if you're sicker, you have more problems paying bills. That kind of makes sense, right? If you're not sick, you don't go to the doctor, or you only go once a year or whatever, you wouldn't have as many. So the worse your self-assessed health is, or if you've got activity limitations, you're more likely to be facing problems. This is national data. African Americans are more likely to face problems than non-Hispanic whites. Curiously, and I don't have an answer for this, Hispanics are less likely to report problems paying bills. So one of the challenges here is this is self-report, so subjective problems paying bills. Other analyses I've done, I've looked at quality of care received by different racial and ethnic groups, and Hispanics get lower quality of care, and they report higher satisfaction with it. So the problem with some of these subjective criteria is that they're hard to pin down, but African Americans reported that they were more likely to have problems paying bills. The oldest age group is the least likely compared to the youngest age group. And so this is compared to those under the federal poverty line. Those right above the federal poverty line, the hidden poor, have exactly the same rate, the same odds of having problems paying bills as those below the federal poverty line. So there's really no difference, which is part of the argument around the elder index, is that this larger group that you're capturing actually has the same problems and experiences as the group that we officially register as poor. And then you get higher income, no surprise, the higher your income, the less likely you are. So the red line is, if it's above the red line, you have more problems. If it's below the red line, you have fewer problems. Medicaid. Medicaid protects you from having problems paying bills because Medicaid is supposed to cover all of your bills. So that's like the sniff test. Does your data make sense? Yes, so you get what you find there. And renters, even after controlling for health status and race, ethnicity, and age and income, renters are 50% more likely to report having problems paying for medical bills than non-renters. And so once again, that indicates sort of the precarious situation that they're more likely to be in that has an interaction with all the other problems. And the larger a family you're in. So it's not just you, but it's you and your spouse, or you and your spouse and some grandkids, right? So you may not be in bad shape, but you may have problems paying bills because you've got other sick family members. And then the same, so I talked earlier, the tightrope was like, do I pay rent or do I skip my medication? And so they actually ask, in the last 12 months, did you have to skip medication or did you skip medication specifically to save money? So there's the trade-off in sort of black and white between economic insecurity and access to health care. Same pretty much set of variables, same logistic regression. So this is only people who have a prescription, but most older adults have prescriptions. Age 65 and over. Only 3% of older adults say that they did this. So this is predicting who's in that 3%. But once again, the sicker you are, although activity limitations is not significant there. Here's that Latino is less likely. So that may be perception, I don't know. But you're controlling for income and these other things. If you're near poor, statistically it's the same. So that's the elder index. So everybody in the elder index has a similar likelihood of reporting skipping medications because of money. And it's much lower if you have a higher income. Medicaid, which pays 100% of your prescription, most states, some states, they require a small copayment, but that's very protective. Here's that renting again. So housing is a risk factor. Renting is a risk factor for problems with access to care, independent of your health status, your income, your age, all of these factors that you would expect to have some influence over whether or not you're making that balance of paying the rent or skipping meds. If you're worried about paying rent, you're more likely to skip meds. And then I put this as a separate color and star because otherwise the scale would go off the map. But it's no surprise, should be no surprise, that if you reported that you had problems paying your medical bills, that previous slide, you're dramatically more likely to skip medication, right? If you're having problem with medical bills, where do you make up the difference? And oftentimes it's skipping your medications. Not a good idea. But if you're going to be evicted or you do without your hypertension medication, it may not be, it's a Hobbesian's choice, but it may be necessary. Okay, real quickly, can we do anything about this? So there's a demand side and there's a supply side. So the supply side is how much income do you have, right? If you have a misbalance between what it takes to live and how much you have to live, you can deal with one or both sides. So you can deal with improving health equity by improving economic security at the front end by giving people more income. That can be earlier in life by raising the income floor during the working years. That has two positive aspects. One is they may be more likely to save money for retirement. And if you have higher income, you're healthier in your younger years. So you go into your older years healthier. So the demand for healthcare later on is less. We can improve pension coverage. And I have another hour lecture that I won't give in the next 2 minutes on the difference between defined benefit and defined contribution pensions. So back in the 1960s, most people who had pensions had a defined benefit pension. So I don't know what you have at UTMB. I'm part of the pension elite. When I retire from UCLA, regardless of how the stock market does, I am guaranteed a certain amount of money every month until the day I die. The stock market can go up, the stock market can go down, and it's based on years of service at UCLA and age. That's it. Well, and my pre-retirement income. So that's the defined benefit. Defined contribution is the TIA-CREF, IRA type of model where you have to put money in, And what we know is people don't put enough money in. And then it depends on the rate of return. Most individuals are conservative in the rates of return that they do. So a pension fund spreads out the risk, and so they can take some high risks and get some good benefits. Most individuals take low risks, and so their money grows less fast than if it was professionally managed. And end up with money at the end of life that's a pot that they have to use for the rest of their life. Not a lot of people buy annuities at that point, and so economists nowadays are very worried that a lot of Americans will start outliving their pensions, right? So if you say, okay, I'm going to live to 85, so I'll take out this much money every month, and it'll last until I'm 85, and then, God forbid, you turn 86, and you have no pension left. So pension coverage would make a big difference on improving pension coverage for older adults. And then providing caregiver credits for Social Security. So a lot of women take time out to care for their kids, to care for their parents, to do a lot of other things that then affects their Social Security benefits as they retire. And so this is an area that there's been a lot of discussion about that would improve the economic status of older adults. And then for current older adults, the floor on Social Security could be established and go up. Supplemental security income, which is for low-income elders, could be improved. And there's been all sorts of discussions over the last 10 to 20 years about different ways of mucking with Social Security. Probably the most insidious one is called the chained CPI. 15-minute lecture on that, which I won't give you. But basically, what that does is that reduces the inflation adjustment for Social Security. So then more people would fall into that gap where they're not able to make ends meet. So that's the short answer on that one. You could also deal with the demand side. So what are the needs for income that people have? We can increase affordable housing for either purchase, right? So showed you the best situation to be in, not universally, but the best situation to be in the mix is to have a home that you've paid off. So that's an asset. It's actually the number one asset of most older adults. So if we make affordable housing more available for purchasing, when people become older adults, they'll be in a better economic situation. If they're renting, I need to improve the affordability of rental housing. A very quick example, I'm looking at the time and I've only got 1 or 2 slides left. So Santa Monica, down the street from my house in Los Angeles, was concerned because they've become one of these really high rental cost coastal cities. So they have rent control. So as long as you live in your apartment, the landlord cannot raise your rent more than an approved amount by the city council, which is somewhere between 3 to 5% every year to account for inflation, costs of repairs, and upkeep on the building. But what they found is that there are 5 to 10,000 seniors in Santa Monica who've lived in their apartments for, on average, 20 to 25 years. So that's an unusual group from what I showed you nationally, who no longer are able to pay their rent-controlled mortgage. So we're talking about people, so Santa Monica now is like LA. Your average one-bedroom apartment would be about $1,500, maybe $2,000 a month. And these are people who are paying maybe $700 or $800 a month because they've lived there so long. But that 5% year after year is greater than the increases that they've had in Social Security or whatever their source of income is. And so they're at risk of that involuntary separation from their housing that I talked about. And so the city is experimenting with a brand new program that's just rolling out this summer where they will identify those seniors who can't pay their rent in rent-controlled houses who've been there at least 20 years. So that's a pretty narrow band, but there's several thousand of them. And provide them with just enough, they'll top off their income so that they can afford to stay in the rent-controlled apartment. So they see this as a way of maintaining a mixed income community, a mixed age community, and for a relatively small amount of money, improving the quality of life of seniors in Santa Monica. And then finally, we can link housing to healthcare. Housing advocates look at the huge amount of money we spend on healthcare. 1 out of every $7 in the United States goes for healthcare, and say if we got a little bit of that, we could provide a lot of housing. And the healthcare people say, oh my God, the housing need in the United States is so huge, if we start using medical care dollars for housing, there'll be nothing left for medical care. So the two sides really don't want to cooperate, but there is some pilot programs that talk about housing as healthcare and help provide subsidies for healthcare for people who are very low income, have healthcare needs, and through the Medicaid program able to do that. So that would increase that. And then through healthcare, we can reduce out-of-pocket medical costs, improve health earlier in life. And so what I showed you on the one slide was the impact of Medicaid in improving access to healthcare for seniors. So you often think of Medicaid as women and children, but actually most Medicaid recipients are women and children. Most Medicaid dollars are to seniors. So if you look at eligibility level, from what I could find in Texas, it's about 75% of the federal poverty level for seniors. In California, it's 120, which is higher, but still way below the 200% that you need for an adequate living. So you could raise those limits. The $2,000 asset limit is the same as it's been since the 1970s, so that hasn't changed at all. Massachusetts raised theirs to $10,000, which still is not very much in assets, but there's a lot of ways you could make those who are struggling to make ends meet have less challenges with health care. And somewhat controversial, but Medicare Advantage plans, if they're low cost, could provide some of that too. Okay, so I'm now standing between you 1 minute over and what's in that nice room next door. So in conclusion, it's important to use a valid measure of economic security. So when you hear that less than 10% of seniors nationally are poor, remember that at least that many are so close to being poor that they might as well be poor. Economic insecurity is more common than acknowledged, and it's across race, ethnicity, it's across the country, but it's concentrated among elders of color. So you're about twice as likely to be economically insecure if you're African American or Latino, and all of the problems that come from that. As I showed you, the economically insecure have the greatest challenges in housing and healthcare, and the two interact with each other, right? So the insecure housing, problems with housing, creates problems with healthcare leads to problems with income, leads to problems with housing. So there's no magic bullet. There's no one thing that we can deal with that solves it all. You have to think about the matrix of needs in aging to be able to provide a decent standard of living. We can do fixes through increasing income, the supply, or decreasing costs, the demand, or both. We can do it now for current seniors. We can start earlier in life so that when people get older, it's better. So this is a nice intergenerational. You can do things for kids that help them as seniors. You can help seniors now. You can do it through a variety of programs. And however you do it, reducing economic insecurity will increase health equity. And that's it. Thank you.
UTMB Health, working together to work wonders.